Good afternoon, everyone. We're just waiting for a few moments as all of our attendees log on. So we will start momentarily. Let's give people a couple of moments. We've got hundreds of people logging on. So we're just going to give them a few minutes and then we will begin formally. Thank you.
Hello everybody, I'm Laura McGahey, Executive Director of Sláintecare, and I'm delighted to welcome you to our webinar this afternoon. Sláintecare is, as you know, about providing the right care in the right place at the right time by the right team. And this afternoon our focus is on alternative care pathways. And you'll hear how projects funded by the Sláintecare Integration Funds are showing us how they've adapted work practices and created improved patient care pathways, in many cases providing more care in the community, close to patients' home and contributing to hospital avoidance. We're very much looking forward to hearing from Martin Dunn, Director of the National Ambulance Service, as he tells us about the alternative pathways being delivered by the ambulance service to also provide more care in the community. I hope you find today's webinar both interesting and informative, and I'm now delighted to hand you over to our facilitator, Dr. Gráinne Healy. Thank you.
Many thanks, Laura, and good afternoon to everyone. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement, and I'm delighted you've joined us for today's webinar, the 8th Sláintecare Integration Fund webinar, part of our Learning Network event. We are taking questions during the broadcast, so if asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers for you. The Q&A button is at the bottom of your screen, and if you type in a question, it will come straight into me here. We're very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is, as Laura has reminded us, about providing right care in the right place and at the right time by the right team. And in these webinars, you'll hear how the projects funded by the Sláintecare Integration Funds and some HSE funded work is showing us best practice for healthcare reform and displaying how many have adapted work practices and created improved pathways while responding to COVID-19. This afternoon, as Laura mentioned, our focus is on alternative pathways to care. We will feature presentations from 4 Sláintecare funded projects, which are providing alternative pathways for patients. The projects are contributing to hospital avoidance and improving the experience of people who use our health and social care services. Some initiatives are about moving care closer to home for patients by delivering care in the community. Others are providing interventions which mean that patients don't need to travel to acute facilities for care, while another approach is about providing integrated solutions to patient care. All alternative approaches are leading to a drop in hospital attendances, thus freeing up appointments at hospitals for those in acute need. All of these approaches have clear positive outcomes for patients and for services, and all are helping to deliver models of care as envisioned in both Sláintecare's 10-year plan and the recently published HSE Corporate Plan 2021-2024, aiming to build a responsive and multi-pathway route to care for patients, bringing care closer to home for many by locating it in the community, and thus better meeting patients' needs closer to home by the right team in a timely, efficient and effective manner. But before we meet the four projects today, I am delighted to say I've been talking to Martin Dunn of the National Ambulance Service. I spoke to Martin last week and he was telling me about alternative pathways they are delivering across Ireland, providing new ways of working by the various teams in the National Ambulance Service. Let's hear from Martin now. Afternoon to be able to welcome Martin Dunn, Director of the National Ambulance Service. And in the light of our webinar, which is all about alternative pathways to care, the work that Martin and the National Ambulance Service are doing is really pertinent. So Martin, you're very welcome. Thank you so much. I know you're exceptionally busy, so we really appreciate you giving us the time this afternoon. Martin, would you start maybe by talking to us about why it is that ED avoidance is such an important thing to be trying to do with the National Ambulance Service?
Certainly. Well, hello, Grania, how are you? And thank you very much for the opportunity to speak today on the webinar. The question I suppose you're talking about is very pertinent for a lot of reasons. I suppose ED avoidance, if you want to call it that term, or an alternative pathway for a patient, is becoming more critical on a continuous basis for several reasons. One, I suppose, is in relation to demand management. And let's be honest about it, like the demand for hospital care and pre-hospital care, in line with everywhere else in the world, is continuously rising. So there has to be ways to make sure that the patients who are looking for a level of assistance are getting the right assistance, in line with the Sláintecare ethos of the right care in the right time in the right place. Also, the EDs, as you know yourself, emergency departments, are geared for people who are, I should say, very sick, right? And some people have a definition of what sick is as compared to what very sick is, if you know what I'm saying to you. Yeah. And there has to be adequate space to be able to make sure that the patients that are coming in who are quite sick can be looked after in a safe way, but also in a very timely manner, right? And we need to sit down then and be realistic about it and say, okay, what are we going to do to make sure that patients who really can be diagnosed either through a telemedicine project or even down the phone through clinical hubs, we know that they're the most, I suppose, I'll rephrase that, the place maybe that's not best suitable is ED, right? And can we put alternatives in place that suit that patient's need at that moment in time, that gives them other options, alternatives, so look after themselves, maybe in an environment that's not within the ED. So that's what we're trying to focus on at the moment, and to make sure that that patient is kept safe.
Yeah, that's very good. So it's really ED for those who really need it, and for those who don't, finding appropriate pathways for them. So that's really clear. And I was looking at some of the recent stats that have come from the National Ambulance Service around this issue. And because of some of the initiatives that you have devised and that you're rolling out, there's been a 51% of those calling in managed to avoid ED, so they get care in other ways, in other spaces. Would you talk a little bit about, in particular, the 5 elements from the National Ambulance Service, maybe starting with the community paramedic service?
Okay, well, that's fine, Rania. And you wouldn't mind if I started with the clinical hub if you want.
You start with the clinical hub, okay.
That's all, just because that's the first point of contact.
Yes.
So if you think about the role and function of what we call NEOC, which is the National Emergency Operations Centre, it is a centre point of contact. So when you think about our previous discussion in relation to patients looking for help, if you want to put it that way, the default is always to dial 112 or 999 for a medical or traumatic emergency, which is the correct thing to do, and we'll always encourage that. When that actual situation is triggered by the patient, right, and we go through what we would call a triage system, an algorithm system called Advanced Medical Priority Dispatch, it allows us to engage with that patient in a way that we can come up with their clinical requirements at that moment in time. And we can say to them in a safe way, listen, maybe we can do this a different way. And if you're happy enough to do this a different way, we'll go across onto a different level of system, which is not an emergency ambulance dispatch at this moment in time, right? Yeah. And in most cases, what happens then is we can put the patient onto a system that we have called low code, which is staffed by doctors. And that's within the clinical hub, right? And that means that that patient can actually be put into a virtual waiting room and then taken into a virtual consultation room in quite a timely manner. There's no major delay. And they can interface with a doctor, right? Or one of our advanced paramedics that may be available at the time, and discuss their clinical presentation at that moment in time. And based on what goes on in that conversation that goes on, I suppose decisions can be made as to the proper pathway for the patient.
exactly.
And because it's a doctor, there's a level of comfort. So when we come to that decision, we decide, okay, what's the most appropriate dispatch type for this particular patient at this moment in time? So we have to have processes in place, like you said, right, that makes us to allow us to dispatch something to that patient to manage their care. If in some cases self-care is just not 100% appropriate, right? So that's the role and function of the clinical hub. And they've now talked to a doctor, and there's a level of safety and comfort around that for the patient. So what we can do then is we can send out what we have now, an initiative called community paramedics. Again, predominantly based in the communities, liaising directly with GPs, community nurses, etc., and are dispatched from the control centre. They can go directly out to that patient's home, review the patient based on what the information they have. If it's a medication issue, we can liaise directly with the GP. We can use telemedicine in some cases back to the GP, and the GP can have a three-way conversation with the community paramedic, with the patient, and indeed with the GP. And we might make a decision that we may need to nip down to the local pharmacy and change some sort of medications that the patient might be on,
Right.
etc. around that. Or it could be other things like interventions around catheter changes and problems, which in fairness do not need patients being brought into the ED, and we can manage those situations as well. Sometimes it can be just social situations, and we can interact on that level as well, and we can assist with that, right? And I mean, as you know yourself, during the course of the pandemic, it can be quite lonely for people as well, and they can be slightly over concerned, and sometimes a cup of tea, a little bit of a chat, have a look through the meds,
down. Yeah.
reorganize the medications in a way, have the chat, but also make sure that there's that callback. So we will always make the call back from the community paramedic, from the response card, to make sure the next day that everything's okay. With a default as well to say, if you're feeling any worse or not well, dial 11299 and we will go back out to you again. And that gives people a less isolation and a level of comfort.
Yes.
And it's at that low level, and it works extremely well. So in the main, people are maintaining their own self-respect. They're staying at home where they want to be, let's be honest. No one wants to get into the back of a yellow ambulance, let's be honest. They might need to, but in a lot of cases they don't want to. And it allows us to do that for them. So that's the first pathway we would look at, right? The second pathway is we'd have the Pathfinder project, which operates in the Beaumont catchment area, and as you know yourself, has been quite heavily supported by Sláintecare and indeed Beaumont. Very successful again, and that responds to, in the main, falls, if you want to. So we have calls coming in on the 999 line where there is a fall has taken place, a slip or a trip or whatever, and we can send out a response card, an advanced paramedic with an OT, say from Beaumont or whatever, and other specialists if required. And we can examine the patient in the first place. We can do an economic assessment as well of the area as well. We can have a look at the social setting of the patient. And if possible, then we can manage that patient in their home environment, and they can help manage themselves. And again, the Pathfinder project has allowed us to interface with other parts of the HSE, where simple things that can be done as part of the ergonomic assessment, like whether it's steps, could be a simple thing as a stair chair, it could be a simple thing as a toilet
grip
seat.
rail, yeah,
correct.
Something,
anything like that gives that patient a little bit more ability to manage themselves safely and remove any of the I suppose challenges that may result in further issues of trips, slips or falls. And it saves us bringing that person into the ED again and to go through that process. And again, very important here is the callback. And there's actually a relationship building going on with Pathfinder. It's a little bit even more than a callback. We now have maybe friends, if you know what I'm saying to you. And it's a general chat and how are you? And that gives that person a level of self-confidence and to maintain themselves in their own community.
Ambulance emergency. Call you through to the ambulance service. What's the phone number you're calling from? And what is the address of the emergency? Okay. Tell me exactly what happened. Okay. So your mom had a fall last night, is that correct? Okay. Okay, Mary, so we're going to refer you to one of our doctors in the clinical hub.
So Mary, it looks like from what you're telling me, you'll need an ambulance, all right? So we'll send one to you as soon as we can. Now, if things do change in the meantime, don't hesitate to call us back.
Five Bravo 2 to control. This lady we've assessed, she's suitable for an alternative care pathway. If you wouldn't mind mobilising the Pathfinder to this scene.
Roger, 5 Bravo 02. I'll assign Pathfinder to the call.
So that's been very successful. And again, it's an alternative pathway that works, and we know it works. We also have introduced below in the south what we call the pre-hospital alternative pathway response model, right? Slightly different in the pathway, slightly different to the community paramedic, but again has elements of all of them encompassed, right? Where and again, an ambulance response vehicle with a special reg from the hospital, advanced paramedic and or a paramedic in that case, depending, respond to, again, low acuity calls that are tagged and trigged through the low acuity desk to say, this may not need a full ambulance to transport at this moment in time. And we go out and we review a wider scope. And again, there is alternative pathways made. It could be GP contact, it could be a mental health contact, or whatever is required. And again, it could be simple medications, a little bit of comfort, self-care, how you look after yourself a little bit better in the home setting, and or we need to get an ambulance out. And again, if we decide at that call we require an ambulance to bring this patient in, it's in a much more controlled environment. And we can go out and bring the patient into the ED nearly at a, I won't say exactly an allotted slot, if you want to put it that way, but at a time that everyone knows the patient's coming in, including the patient. And again, in the Dublin area, we have a frailty car again, which it works out of St. Vincent's Hospital, again, quite successful. Same criteria. I don't like using the word elderly because I'm nearly part of that criteria myself, and there's nothing wrong with that. But again, criteria driven in relation to certain clinical presentations, again, around slips, trips and falls, minor ailments, minor injuries. And again, from Vincent's Hospital, you can send a team out there in a car to the patient's environment. And sometimes it might be in the home, it could be in another environment. And we can review that patient and go through the same process, right?
Very good.
And the importance of the whole thing is that the patient is getting a response that suits the clinical presentation at that moment in time in a safe way. They're getting interactions with ourselves and with doctors, either from the hospitals and or, all right? And that the patient is getting a pathway that's suitable for their needs, which may not be the ED. And it builds up relationships, a level of confidence in the community as well, that the health service executive through Sláintecare and other initiatives are focusing on trying to keep people within the home environment.
No, it seems to me that two things that I've heard you say that I think will give people confidence. The callback, I think that's a fantastic idea, that if you don't end up going into the hospital, that there's that callback. And I think that that's really comforting for people, especially if you're living on your own or maybe you are elderly, that idea that you're not just not being taken to the hospital, you're actually have your needs met, and there is a callback so that you could say, do you know, I still feel dreadful. I still don't feel I'm able. And you'll say, okay, in you go. And that the second thing is about the more controlled environment. So it's in a more controlled manner. It's not lights blaring and, oh my God, we're all in a panic and everyone is up to high dough. I guess all of this is happening in terms of the National Ambulance Service. You are migrating, you have the future model of care, as you call it, migrating from an emergency medical service, which you have been for so long, to a mobile medical service. And I think we can see that clearly in the examples you gave there of some of the alternative pathways. Do you want to just speak briefly about that to conclude?
Yeah, certainly. Again, thanks for the opportunity. We call it the long-term evolution of the service. I mean, let's be honest, nothing stands still, time moves on. So in fairness, when you look at what's going on around the world and what's going on in Ireland and the requirements, whilst emergency medical service, which is the blue light, as you say, response, is a hugely important part of what we do every day of the week, right? We do know that things are changing. And we do know that lifestyles are changing, and the requirements around lifestyle change is slightly different than the straightforward trauma system or the collapse or whatever it might be. So, and again, in line with, I suppose, the ethos of Sláintecare, more further integration into the community, being seen in the community, and doing work within the community and with the patients within the community to improve their overall health and well-being, not just at that moment in time, right? Their overall health and well-being is what we're trying to do. So we're trying to embed those initiatives out there in the community in a safe way, right? Slowly, but in a safe way, to say that we're there now and we'll try and manage it at home.
Yeah, very good. And maybe just to finally conclude, I mentioned at the beginning the 51% of emergency department avoidance, and I think it's a really stark statistic. But I also just want to conclude by saying, you know, there are real cost savings in this way of working, and I'm looking at one of the figures there, about €705,000 saved. This is money that can be put into other elements of the service. So you really are doing your bit to do the right thing in the right place at the right time. Martin Dunn, thank you so much for your time and your expertise and all the good work that you do. Thank you so much for joining us today. So a great success story there, showing clearly how the National Ambulance Service is changing how it works in order to meet its objective of finding alternative pathways to care for the call outs that it answers 24/7, 365 days of the year. Great work. And again, thanks to Martin and all those working with the National Ambulance Service, creating these alternative pathways. We have 4 projects doing innovative and effective change work, leading to alternative pathways for patients and service users to showcase for you today. The projects are both providing alternative pathways and are improving the experiences of people who use our health and social care services. As Sláintecare continues on our journey to ensure right care, right time, right place, these projects allow us to demonstrate to you what Sláintecare alternative pathways look like on the ground. Our first project for you this afternoon is Integrated Care for Older People, Model of Falls Prevention and Management. This project is a joint venture between CHO1 and Sligo University Hospital in the Sálta Hospital Group. I spoke earlier to Melissa Currid and Adele Brennan from the team about their approach, and Dr. Fiona O'Sullivan, consultant geriatrician, features also, taking us through the improved outcomes for patients. Let's hear from them now. Very pleased to have the coordinator of the Integrated Care for Older People Model for Falls Prevention and Management project, Melissa Currid, coordinator. You're very welcome, and we're so pleased that you could join us. Melissa, I am aware that the project has been operating in CHO1 and across 5 different areas, but the project originally aimed to reduce emergency attendance, to reduce the length of stay in acute hospitals, and to reduce the waiting times. Tell us a little bit about the model that you're using. What is the approach that you've developed to attain these outcomes?
Okay, so the Integrated Care Programme for Older People was established in Sligo Leitrim in 2016. In fact, it was one of the first 10 pioneer sites in the country. And as part of that programme, a falls work stream was established with a consultant geriatrician as the clinical lead. Now, prior to this, in CHO1, we did have an existing model of falls prevention in the community setting, which was managed within older person service and supported by primary care services. And it was local data collected from this service that identified the need for a ring-fenced multidisciplinary approach to falls prevention. So this is why in 2019, the proposal for this integrated model for falls prevention was submitted to Sláintecare for innovation funding. And as you mentioned, our project aims were to reduce emergency attendance to the acute hospital, reduce length of stay, and a reduction in waiting times for falls clinics. And we aim to achieve this by having a specialist team in the community setting aligned to the Sláintecare vision of right care, right place, and right time.
Excellent. And
Yeah,
so using this integrated team approach, essentially ensuring that people are prevented from falling. If they do fall, they see this integrated team, and in that way achieving these outcomes that you've set of reducing emergency attendance, length of stay, and reduction in waiting times. And you have had some success in this. Tell us a little bit about how the project has gone for you.
Okay. Well, we have. In fact, we've surpassed our outcome of reducing our waiting times. We've actually, well, prior to lockdown 3 anyway, we had reduced our waiting times from 5 months to actually 2 weeks and less in some cases. So that has been fantastic. And it's because we have the specialist team dedicated to the service that this has happened. Prior to this, we didn't have the dedicated team. We were utilising resources from within older person services, from within primary care. So having the specialist team has allowed us to achieve this. You know, we are seeing in our outcomes, we are seeing to date, even with the restrictions imposed because of COVID, we are seeing positive outcomes with regard to reducing hospital admission and hospital avoidance.
And I know one of the elements which on the one hand was a problem in terms of COVID and not being able to see people in clinics, but you did a pivot and instead you started to do domiciliary care visits.
Yeah.
They've been really successful for you, haven't they?
Yeah, I mean, we refocused, particularly when, you know, level 3 we had to, because with, you know, the levels and the restrictions, our walk-in, our outpatient outreach clinics couldn't happen. We had to pause them. So we refocused and we concentrated solely on domiciliary visits. So that meant that our team, our clinical nurse specialist, was going out to the person's home, undertaking the full multifactorial assessment in the home. Following on from that assessment, she was then referring to the appropriate service. Our physiotherapist would go out, complete her assessment, undertake interventions such as exercise programs. We have our therapy assistants on the team who would then also attend the patient's home and carry out the reablement type interventions with the person in their own home.
Very good. So being able to, although it was a challenge, actually being able to move to those visits has been, I think, a huge part of your success.
Absolutely.
The other element of the program that I'm particularly interested in, and again, perhaps I'll go to your colleague Edel for this one, is talking about the timed up and go, the exercise program that the physiotherapists are running. And I think a lot of the reduction in frailty risk is down to these classes. So thanks very much, Melissa. We go to Edel now and talk to the senior physiotherapist. Thank you. Edel Brennan, you are very welcome. Senior physiotherapist with this project. I'm really interested in the timed up and go, this particular element of the program that you've had such success with. In particular, I want you to tell people what is the program and also the difference between the at risk of falling from week 0 to week 10. It's a phenomenal statistic. So over to you, Edel.
Thank you. In autumn 2020, we set up a 12-week course of evidence-based strength and balance exercise classes under the guidance of infection control. Now, our aims as a service is to meet all the needs of the older adult, those who are at the active age, ones who are in transition, and the frailer older adult. So what we do is we have 4 classes of varied levels. So, and I use the evidence-based programs, the Otago and the FAME program. So this ensures that each client gets the right service at the right place at the right time. So because we all know that one size does not fit all. So you asked me about our timed up and go measurement. So it's very important to evaluate our service, and we feel really strongly about this. So we looked at a lot of strength and balance outcome measures, and we took them prior to the classes and after completing the course of classes. So the timed up and go, this is a measurement which determines if someone is at risk of falls. And what the standard measurement is, if someone can do this test in under 15 seconds, they're deemed to be not at risk of falls. So prior to attending the classes, 54% of the participants were actually doing the test in over 15 seconds. So therefore they were at risk of falls. And after completing the classes, plus, let's say, and it's very important, a home exercise program to get the adequate dose, this number dropped to 8% of the participants.
Wow.
Yeah, but the good thing about this was it just shows that a tailored, evidence-based, progressive, challenging exercise classes can help to minimize the risk of falls.
So Adele, this is really about supporting and encouragement, the self-management by people themselves, knowing the exercises, the strengthening. And I noticed somewhere the evidence saying, you know, it's not falling is the problem. It's being able to get up after the fall. And that's really a lot of what you're doing, is providing people, isn't it, with the strength and the ability to recover, get up, and if possible, not to be at risk of falling, or reduce that risk.
Yes, because as Dawn Skelton always says, we will all fall, but it's having the ability to get back up. And if people know, if we are able to give the people the tools to get back up if they have the fall, that reduces their anxiety and reduces their fear of fall. And that enables them to live well in their own homes.
Excellent. Adele, thank you very much. And thank you to your colleague, Melissa, and to everyone on the team. And best of luck with the rest of the project. Thank you so much.
Thank you very much. Thank you.
It's great to have you coming into my house rather than me going to a clinic. I'm looking forward to the classes starting because it might motivate me to do a bit more. Okay. But it'll be good to get out there because I'm better if I go to a class. I've been living alone, so a bit of interaction with yourselves is great. And you know, you ring up and keep an eye on me, and you've been very good.
Good. One foot in front, the other good, as if you're walking in a straight line. Keep looking that. If you're coming steady, can you just take a step to recover?
Hi, my name is Dr. Fiona O'Sullivan. I'm a consultant geriatrician in Sligo University Hospital, and it's a pleasure today to speak about my experiences of working with the Sláintecare Integrated Falls Prevention and Management team in Sligo Leitrim. I was originally involved in the work streams that we would have put together a couple of years ago when we were a pilot site for developing integrated care pathways for older people in Sligo Leitrim as part of the National Clinical Programme. And we would have highlighted some deficits at the time in terms of timely assessment and management of older patients in our area who've had a fall, or indeed who've had a fear of falling, which in itself is a risk factor for future falls. So it's really exciting to see this team now that's come into operation that has filled up a lot of those gaps in the region in essence. It also means that when I see patients in other settings or other contexts where it becomes apparent that falls are an issue, that I have a highly skilled professional team who I can refer that patient out of secondary care to with confidence and either facilitate earlier discharge or limit the risk of future readmissions, either to the emergency department or via the hip fracture pathway, for example. I think the advantage for the older person is that it's bringing care closer to home. It's improving their quality of life and reducing the risk of a really serious adverse event, which can totally change the trajectory of an older person's life. And as we all know, this is an ever-growing but very important cohort of people that we care for in our health service.
Great to hear there from the patient, Anne-Marie, as the team work, as she says, to keep an eye on her. Also to hear Dr. Fiona O'Sullivan conclude the clip with an overview of the advantages and the improved outcomes for patients to whom they're delivering their service. Well done to Melissa, Adele, Fiona and the whole team. Our second project this afternoon is COPD Integrated Care Project, developing an integrated community-based response to care for people with COPD. I spoke with 5 members of the integrated team earlier. So you're very welcome. We have a whole team for you to meet now this afternoon. This is the COPD Integrated Care Project from the sunny southeast down in University Hospital Waterford and in the community there. Many of you will know that there are some 110,000 people living in Ireland who have been diagnosed with COPD. The true number of people living with this disease is estimated to be over 380,000. We're going to hear from a team this morning who have received Sláintecare Integrated Funds money to address many of the priority service gaps that they have identified, and they're delivering an integrated community-based approach to care for people with COPD. We're going to meet, first of all, the project manager, Linda Ennis. And Linda, we might start by you just telling us what is COPD, and then you can introduce your colleagues and tell us about the roles that they're providing. You're very welcome.
Thank you very much. Yeah, so we set out with the aim of this project to deliver, I suppose, improved quality of life for patients in our Waterford area with COPD.
And what is COPD?
Oh, chronic obstructive pulmonary disease.
Great.
Yeah, and we have quite a cohort of patients in this area. We have 2 consultants, respiratory consultants, delivering specialist care in the area. So what we wanted to do was to align our services with the National Clinical Programme model of care, to deliver care very much aligned with the Sláintecare, closer to home for patients, in primary care settings, to establish hospital avoidance interventions and supportive discharge for those who have to come in, to transition them back into safely into the home, and to keep them well and prevent them readmitting again, which, you know, we had a reasonably high readmission rate. So I suppose we had a number of components and outputs we wanted to deliver, and Philomena might talk a little bit more about those different components and deliverables that we had envisaged at the start.
Hi, thank you very much. So yeah, our COPD Integrated Care project runs collaboratively between University Hospital Waterford and the South East Community Healthcare. Our team is a multidisciplinary team comprising of a lead respiratory consultant. We have 2 respiratory specialist nurses. We have 1 senior physiotherapist and 1 senior dietitian. I suppose our objective is to facilitate individuals with COPD in the Waterford City and County area to reach their maximal health and quality of life potential, and to address their COPD with maximum clinical outcome effectiveness and efficiencies, I suppose. A key focus being person-centered care. We try to ensure that care is responsive to patients' wants, needs, and preferences. The project itself has 5 project deliverables or outcomes. So we would have the acute care or in-reach service. We would have an COPD outreach service for patients in the community that are well in the community. We have specialist COPD ambulatory care clinics that's run in Waterford and Dungarvan primary care centres. We provide an early supported discharge service in our clinics, and we have outreach pulmonary rehab service. We've also developed a criteria-based referral system and pathway for GPs for ED for the outpatients, and for inpatient acute care for patients with known COPD. All patients that come to our clinics, they receive a patient-tailored action plan informing them of how to recognise an exacerbation and to treat that exacerbation accordingly. It also includes inhaler technique and management and nebulizer care. It includes exercises and airway clearance techniques, as well as dietary advice. So it's all individual and tailor-made for each patient. I suppose we strive to instill confidence in our patients to facilitate them to change their behaviours and take responsibility for their health. And we try to take a proactive approach to reducing the disease burden and hopefully mitigate the impact of the disease on exacerbations and the symptoms.
So my name is Juby. I'm working as a respiratory CNS in the COPD Integrated Care Service. So since we started the project, our main aim is early supported discharge of the patient and post-assisted discharge for our COPD patients. So we set up a SOP, and according to our SOP, we have a pathway that decides the inclusion criteria and the exclusion criteria that we select the patient from them. And once the patients came in the emergency department, The ED or the medical consultants already review the patient and they assess. And once they diagnosed their COPD, they go through the COPD Performa, that COPD management bundle. That's a significant step we have took forward to bring up in this service. That's helping us in tailoring and acute management in a most efficient way, as Philly explained, more person-centered to improve their health-related quality of life. So once we have selected the patient, the nurses will be assessing the patient over there. And if they meet the criteria, our aim is the discharge within 72 hours. So if the patients are not able to discharge within 72 hours, we will be still following up them. They may need some kind of hospital intervention past 72 hours, but we are frequently following them and try to do an early discharge with our support service. We link with the CIT, that the community intervention team. So this team will give the home visit for our patients to make sure they are safe at home. So once the patient been discharged, we are giving a follow-up appointment in our clinic within 7 days. We kind of aiming within 3 to 5 days, depends the severity of illness they've been presented in the hospital.
So each month we report outcomes related to each of the key outputs of the project. With regards to our ambulatory care clinics, the teams provide self-management support for patients in order to live well at home. And we do this with the aim of reducing hospital admissions for our patients in the community. And we've also created a number of alternative referral pathways into our service for GPs, as well as for ED and acute care. So with regards to our acute in-reach service then, 57 of the patients who were admitted to ED with an exacerbation of COPD then went on to be seen in our primary care clinic since the commencement of the project. And 100% of these were offered follow-up within 7 days of discharge from hospital. We've conducted an audit in December and found 75% of patients presenting to ED with an exacerbation had the acute care bundle implemented. And since this audit, we've continued with education and staff training, and we're striving to aim for a result of 100% completion rate at our next audit. Then in terms of our outreach service, there has been 111 patients seen in our clinic since the starting of the project in mid-September. And each of these patients receives input from the CNS, the physio, and the dietitian on multiple occasions. There has been a 49% reduction in acute admissions of patients with a primary diagnosis of COPD between the months of October and December, compared to the same period in 2019. As part of our assessment of patients, we use a number of validated outcome measures to gauge the progress of our patients throughout our time seeing them in clinic. So we record outcome measures on areas such as breathlessness, quality of life, malnutrition, exercise tolerance, and overall management of their condition. Additionally, our patients are sent an experience survey. So the survey asks patients to rate their experience and also their confidence in managing various aspects of their disease. And 100% of respondents reported that they were satisfied or very satisfied with the service. And a further 75% of respondents reported an improvement in their confidence in managing their condition after seeing us in clinic. With regards to our early supported discharge service, a total of 57 patients have been supported in our clinics following discharge, and the average length of stay for these patients was 5.8 days. And this is a reduction compared to the baseline figure of 6.4 days in 2019.
Very good. So they are impressive figures in a project that started only in September. I think that last one you gave us of the readmission figures being down and in fact being lower even than some of the earlier stats that you'd given us. They're great outputs. Thanks for sharing those with us. Thanks. So finally, Emer, I think we're coming to you. You're very welcome.
Thank you very much, Grania. I'm just going to talk quickly about our outreach pulmonary rehab service, which we've started here in UHW. So far, we've run 6 virtual pulmonary rehab programs, and that has included 43 participants. Our virtual pulmonary rehab programs are, of course, in response to the COVID-19 pandemic, where our traditional model of pulmonary rehab had to be ceased. So yeah, we've done very well. 6 programs so far. 100% of patients have demonstrated an improvement in their physical fitness, which was clinically important. And 100% of patients have also shown an improvement in their dyspnea scores. Our quality of life improvements were a bit lower, but that is comparable to other chronic diseases, and we're working with that as best we can. And as we are running our clinics, we are also referring people to the pulmonary rehab service, which is showing a pathway for patients who are in the community to improving themselves after having an acute exacerbation. 72% of people who are assessed in our rehab clinic, in our acute clinics, have actually been referred to a pulmonary rehab waiting list. So that's very important for our patients to have that continuity of care post admission. I guess when we speak about COVID and its impact that it's had on our pulmonary rehab service, it has also had a big impact on how we've run our integrated care clinics. But we prioritised the clinic in our plans and made sure that patients who were required to be seen post-discharge were seen in our clinics. And I guess we've shown a lot of adaptability and sustainability in the service, that it has been run virtually in a massive way. A lot of our consultations were done through phone or video for patients who couldn't present to the clinic, which was very high priority to us.
Yeah, great stuff. Okay, listen, thank you so much for sharing all of that. I think your outcomes are very, very promising. And you know, as you say, the idea of, you know, how is people's quality of life? I think it's hard for all of us to be giving 10 out of 10 in terms of quality of life, but it does seem that supporting the self-management and the facilitation of ongoing care for people with COPD is really getting the kind of outcomes that you were looking for, particularly ensuring that people who don't need to be in acute settings are not there in acute settings. So good luck with the project. Linda, thank you for bringing your team to us, and thank you, each of you, for the work that you're doing. Good luck with the project. Thank you very much.
Now, David, would you like to tell us your experience of coming to see us in the clinic?
When I was in Arkeen for a good few months, when I came out of Arkeen, I came up, I met Julie, the nurse in Arkeen, and she invited me to come up to Johns Hill, and I never looked back. I'm coming here 4 months, and as you say, I have to speak my mind. The 3 nurses up there are fantastic. That's all I can say. And I never came out or done happy. And I'd advise any people in Waterford, if they have anything to do with COPD, go up and see them girls and they sort you out. And also, I should have mentioned that it was easier for me to come to clinic than it is to go to the hospital, because it's not easy on me for parking and this and that, but
Thank you to David Griffin for his testimony. As he says, he's never looked back since accessing the clinic in the community. And you know, there's no doubt that issues such as having the service close to home, ease of parking away from acute settings, they are important factors for patients, supporting his ease to attend this very important COPD service in the community. The third project I have for you this afternoon is a community-based oncology service. I met with some of the team earlier, and here they are now to tell you about the model of community-based service they are developing. Project that we're going to showcase this afternoon is the Community Intervention Team Dublin North City and County Community Oncology Service. This is really an alternative pathway for stable oncology patients with service and care delivered in the community. As you will know, people are living longer with cancer, which is putting increased pressure and demands on cancer healthcare services. Recent figures from the National Cancer Registry predict a potential doubling in the number of cases by 2045. We're really pleased to be joined this afternoon by members of the team from the Dublin North City and County Community Oncology Service. And I'm going to speak first of all to Deirdre Carroll from the team. Deirdre, you're very welcome. And Deirdre is the nursing lead for the project. Deirdre, would you tell us a little bit about what it was the project set out to do when you applied for Sláintecare funding to develop this model of community-based care?
Sure, Grania. Thank you very much, and to Sláintecare for giving me the opportunity to talk about this project. The idea for the service improvement came about in 2018 when CIT set up a working group with the Mater Cancer Directorate to look at the possibility of delivering oncology treatments and nursing interventions safely in our community-based nurse-led CIT clinic. One of the aims of this group was to enhance the care provided to cancer patients. We wanted the CIT service to complement the existing oncology service by transferring some oncology care to the community setting. The group wanted to identify stable oncology patients and streamline their treatment pathways. We looked at international advancements in oncology and noted that community-based cancer care was the focus in many areas in order to increase capacity within acute services and improve the patient's experience.
Very good. So in many ways you were trying out a model that had been tried in other places, but this is the first time this particular gathering in this community were working on it. Talk a little bit about some of the advantages of this community-based model, particularly, I suppose, for the patients. What are the advantages for them?
So firstly, from a patient's perspective, I think it offers choice on where they would like some of their care delivered. I think spending less time in the busy acute hospital site is hugely beneficial. While of course patients will need to continue to attend hospitals for some appointments, it means their hospital visits are reduced. They spend a lot less time in our clinic waiting rooms before treatments due to the fact that it's not based in the acute hospital, where appointment times are unavoidably delayed by the daily unpredictable workload of managing acute oncology care.
Very good.
I suppose another advantage is our clinic schedule appointments can be scheduled around patients' home and work commitments. There's no day case or car parking fees, and for some patients, it's closer to home. Patients can also get their hormone treatments administered and blood tests carried out while attending the CIT clinic. Our clinic is small, so there's a maximum capacity of 6 patients that can be seen at a time. So it's staffed with experienced oncology trained nurses, and it's the same nurses that see the patients each time they visit.
And Deirdre, just finally then, I know that you have engaged patients to get their feedback, and you have a patient rep indeed on the team. How's that going? Is that worthwhile exercise, this engagement of patients?
Absolutely, yes, it's so important. Really, it's not a quality improvement unless it's better for the patients. That's really important. And I suppose in CIT, the center of everything we do is that the patients feel the benefit of the service. You know, we don't want to duplicate a hospital service. We are a community service, so we see ourselves as complementing that and improving the journey for the patient while they're attending oncology care. Some of them are attending oncology services for several years, so if some of it can be delivered out in the community service, we feel that's really good for patients.
That's great. Deirdre, thank you so much for your time this afternoon. I'm going to speak with your colleagues now.
You're very welcome.
Thank you. I am very pleased to be joined this afternoon also by 2 other members of the team. Professor John McCaffrey, who's the consultant medical oncologist and clinical director of Cancer Directorate in the Mater University Hospital in Dublin. So I understand we're having a little internet drop issue going on, so just bear with us, and we will be back up online in just a moment. Thank you very much for your patience.
Clinics, but these patients attend in person in a safer way to the satellite unit, where we can be happy that they've been evaluated, potentially specific symptoms evaluated in person. But there's no doubt it's been a huge advantage in terms of feeling that the patients have been safely looked after. We have kind of safety nets built in with weekly dry rounds and email correspondence about specific patients. So it's been a huge advantage for us as a service in terms of hospital avoidance.
Yeah, and I think even for those of us who've had to travel to acute hospitals, as you say, the parking, the payment for the parking, all of those things can add even to the stress of trying to bring somebody, maybe my mother in my own case, in and out of these. Whereas the idea of driving up to Glasnevin and just coming in, it's such a relief all round, I think, for patients who are in cancer recovery. Thanks very much, John, for that. If I can go to Kathleen now, your colleague, and Kathleen Osborne, you're Assistant Director of Nursing Cancer Survivorship with the National Cancer Control Programme. One of the elements of the programme that we wanted you to look at, one of the outputs, has been the development of an advanced nurse practitioner post in community oncology. Would you talk a little bit about how this benefits patients living with a cancer diagnosis, Kathleen?
Thank you, Grania. So the advanced nurse practitioner is the most senior of the clinical nursing grades, and having an ANP as part of the service, I think, ensures that you have an on-site oncology practitioner with the knowledge, skills and expertise to lead the service and in turn improving patient outcomes. So if I was thinking of the benefits for the patient, I'd probably categorise it in two ways. One in terms of the expert caregiving, and the second in terms of clinical leadership. So for a patient physically attending the CIT service, the ANP will be responsible for clinical decision making at advanced practice level, and working at the advanced level means that the ANP will provide the full episode of care. So that means a health assessment, planning and initiating treatment, and addressing survivorship issues such as the consequence of disease or treatment side effects. So all of that is supported by policies, procedures, protocols and guidelines, and clear clinical governance that Prof McCaffrey talked about earlier. So having that clear clinical governance is of critical importance in my eyes, because it ensures the ANP has the competency, the authority and the autonomy to operate at this level. And really, once you go through the ANP setup, the roles and responsibilities of all stakeholders are really clearly identified, and the clinical leadership is provided by nursing and medical leaders. So from their perspective, I think that's really critical in ensuring patient safety and minimising risk. So for that patient who attends the service, they'll have the reassurance that the complete episode of care is being managed by an expert in what you both talked about there earlier on, that bespoke service that's set up just for this. So it's enhancing the quality of care delivered to the patient, but equally freeing up capacity in the acute services to allow for more complex elements of care to be carried out. And equally, the ANP will always ensure, working with the acute services, that there is access back to the service if it's required, and it will happen in a timely manner. So it reassures everybody, I think.
Yeah, that's great. And in terms of, cancer nursing developments in the community, how can the NCCP support that?
Yeah, so there's, I suppose the team are constantly looking at ways to align the work of the acute and the community services, and there's some good collaborations already in place. But again, if I was thinking about it, the way we support nursing developments is generally through forums and education programs. So already we've got an ANP nursing forum in place. There's 53 ANPs in haematology and oncology in the country, and Caroline from the Glasnevin and service is part of that forum. So that's always a great opportunity to ensure that work is aligned, and equally for professional development and for the peer support piece to go on between nurses.
Very good, thank you. And John, can I go back to you for a last word? In terms of the model that you have devised and delivered and you're getting the outcomes, replication and sustainability, what's needed in your view?
I think it's very much sustainable and replicatable around the country. I think the most important thing is buy-in from all the stakeholders, early engagement. I think information such as you're providing today will be key to anybody who has any doubts, perhaps doesn't have the infrastructure. A shared conversation about how we have gotten to where we've got to and identified the obstacles to getting it over the line.
Very good. So thank you to all three of you for joining us this afternoon, and keep up the great work. Thank you so much for joining our webinar.
And I find it absolutely wonderful. The staff couldn't be nicer, couldn't be better, couldn't be more helpful. It is very easy for me to get to. I can walk up and down. It only takes me 20 minutes. I can get the bus, even drive up, there's no parking. I can have a laugh and a joke here with the staff, regular customer. It's nice, it's lovely, it's clean. In and out in very short while. I'm treated with respect, and we have a good chat, talk about everything and discuss everything properly.
Thanks very much. John Breheny there finishing that clip, a man who can walk to the service, get his care, and even, as he says, have a laugh and a joke with the staff. Well done on this innovative model of care service delivery and this alternative pathway for oncology patients. Before we go to our final project, just to apologise, we had a bit of a hiccup earlier on with our internet connection. It's only happened us 1 in 8 webinars. Isn't a bad result, but apologies for it. I think it knocked some of you out. Our final project this afternoon is delivered by Tala Hospital and is called Integrated Care for Patients with Leg Ulcers. I spoke with members of the team earlier. Let's hear from them now as they tell us about the work they're doing to provide care in the community for those suffering with leg ulcers. Very pleased to be joined this afternoon by almost the whole team who are involved in a really interesting piece of work that's happening out by Tala University Hospital, integrated care for patients presenting with leg ulcers in Dublin South, Kildare and West Wicklow. The prevalence of leg ulcers in the community in Ireland is running at about 1%. Most of these patients are managed in a community setting using compression bandages. However, in some cases, community nurses will see that, the patient may not have the specialist expertise and treatment that guidelines would insist upon. So this project is dealing with that issue. And I'm really pleased to have with us this afternoon Professor Sean Tierney, who is the consultant vascular surgeon attached to Tala University Hospital. Sean, you are very welcome. Sean, would you take us a little bit through just the background to the project, the clinical impact, and maybe the potential for expansion of this initiative?
Thanks very much, Grania. This is, as you've said, it's actually a very common problem in our community. And in particular, it's an age-related phenomenon, so it's growing quite rapidly, particularly in our area, in the Kildare area, where the population is a little bit older, but it's something we're going to see growing becoming much more prevalent in the Tala area in the next few years. And a lot of the patients who come to our clinic, about 30% of the people who attended our clinic this time last year had leg ulcers or some problem related to leg ulcers. And in fact, a lot of those could in fact be managed in the community if there was some additional equipment and expertise, and if there's ready access to specialist opinion at short notice when it's required. So having identified the volume of those patients in our clinic, and of course the need this year to free up clinic spaces because of COVID, but indeed moving into the future to free up clinic spaces and avoid patients travelling to hospital who don't need to come. We set out to develop the expertise available in the community to allow patients receive a wider range of care in the community, including specialist vascular assessment, so that over time we could reduce the reliance on our outpatient clinics, deliver more of the care to the patients closer to their home, indeed preferably in their own community health centre. And in that way, both improve the care available, the quality care available to patients, and increase our capacity in our outpatients.
Right, so doing two things then, reducing people who don't need to be in acute settings and dealing with their issues as close to home with the kind of expertise that gives them maybe better outputs and better outcomes for that care. In terms of the potential for expansion, we're going to talk in a moment to the two people involved in the two outreach clinics, but maybe Sean, you just talk a little bit about the potential for replication of this model.
So, I mean, using this model just in our local area and recently in the Kildare area, we've saved 600 outpatient visits in the year. Those would all have been to our outpatient hospital clinics. They're now been managed in the community, and that's freed up the equivalent of a clinic a month for more urgent or more complex problems, and has allowed us provide more rapid access for community treated patients who have a particular issue or a problem that needs addressed. We can bring them straight in because we've increased the capacity. And I think that could be replicated pretty much across the country with those two components. Nurses in the community who have some additional expertise and additional equipment, and that's not complex. And then the availability, I think, of expert assessment, access for things like biopsies or urgent treatments in an outpatient clinic at short notice. I think those are the two key parts in order to scale this across the country.
Very good. Let's go now to one of the nursing colleagues that you spoke about. Sean is going to hand over now to Liz O'Neill. As the clinical nurse specialist, will you talk a little bit about the establishment of the clinic in Dublin 24, and I suppose the collaboration that has made it possible to get some of the outcomes that you're seeing? How are the patients experiencing it, and what kind of outcomes are they?
Right, well, hello. My role in this project is CNS vascular veins. Ideally, come February, when I was started in post, my role was to coordinate the service and then have two PHNs in Kildare, one PHN in Kildare and the other in Dublin Southwest. When COVID happened, needless to say, things got shook up a little bit, so we commenced the clinics in February. So the patients come to the hospital or come to the clinic rather than coming to the hospital whatsoever. They get their comprehensive vascular assessment. So it means that we're basically keeping people well in the community, and not the need for coming to hospital is completely taken out of control. So these clinics are set up to avoid patients coming to the hospital and to improve access. So the timely referral is crucial to these clinics, because it means then the delay, you're not waiting maybe 6-7 weeks when an initial ulcer occurs to get your appointment. Yes. You're getting your referral sent in, and you're getting your appointment basically within 2 to 3 weeks. So it's proven that early intervention can help patients. So having this rapid access clinic rather than waiting is crucial. The diagnostic service that we provide in these clinics is crucial because, again, they don't need to come to the hospital. So it's a one-stop clinic, basically. They come, they have their vascular assessment, they have their diagnostics, they get their health promotion, and all this means that they don't need to come to the hospital whatsoever. So again, it's taking the shift in care and taking it from the hospital in the community. Sorry, go ahead.
No, go ahead. So how are the patients experiencing it? What are they saying to you? Are they happy with it? Does it suit them?
Well, I suppose we started at a time when COVID hit. So the patients were hugely grateful that they were able to see somebody in the community and not have to attend the hospital. The whole fear of coming to the hospital was gone. The clinic provides a 1-hour session, so it's one person in and one person out. So you don't meet anybody but me, basically. and the other nurses that run the clinics. Feedback from them, they feel very secure, they feel very safe, they feel that they get the care that they needed in the community, and they also feel that because they can get a timely referral pathway in, they're not waiting ages, so they like the fact that they're treated effectively quicker.
Very good. So let's go over and talk to your other colleague then, Carmel. And Carmel is the PHN in the Kildare Clinic, I understand. Carmel, you're very welcome. Tell us a little bit about the setting up of the clinic there and the kind of collaboration training and maybe some of the challenges you've had so far, Carmel.
Hello everybody, my name is Carmel Neal and I'm a tissue viability nurse down in Kildare, West Wicklow. I have a wound clinic in the primary care centre in Kildare town, and I've been working in tissue viability since 2013. Up to now, I suppose the vast majority of the patients I get into the clinic are with leg ulcers. And I do my own assessment initially, and then if I need to refer to TALA, I will refer to TALA. But with this collaboration, it will mean that I'm being trained up to do toe pressures, which I didn't do before, which is very interesting advance for me through Elizabeth, and she has come down to the clinic and we have assessed patients together. This will mean it should really cut down the amount of patients that I would have to refer to TALA, which will be fantastic for patients. It will be locally held. If I have any queries, I can relate to Elizabeth or to Professor Tierney. It means keeping these people out of hospital, out of the outpatients. It also facilitates patients in that previous to this, when a patient would be going to TALA, maybe for an outpatient's appointment, it would mean a family relative possibly having to take half a day off work to transport them to TALA. Whereas now they can come directly to me. They'll be seen at their appointed time. The diagnosis will be made, and it will make for much more efficient service to patients in the community.
Great stuff. Thank you very much, Carmel. Finally, can I go to Angela? And Angela is the Perioperative Directorate Operations Manager. My God, that's a great title, Angela. You're the project lead here in this project. Would you talk a little bit about some of the other colleagues have talked about, you know, the impact of COVID and maybe some of the challenges, but it seems to me there is a huge amount of teamwork, upskilling, training. There's a lot more going on behind this. Would you talk a little bit about that, Angela?
Yeah, there is. I suppose, you know, I'm always conscious of how lucky we genuinely are here in TALA. There's really great teamwork atmosphere, and from the very beginning, when we were looking for initiatives and projects to, you know, base our applications around, Sean was just so supportive. You know, it was his idea in the beginning and he was so passionate about it, and you know, that kind of flowed over onto myself, and then of course Liz came on board, and we couldn't have asked for better through Liz and Carmel and our other PHN colleagues. So the teamwork was there from the very beginning, and we built on that. And I suppose, you know, we were just starting up, as Liz said earlier, in February, and then COVID came in March. And we were absolutely determined that this was not just going to go by the by. You know, we were so very nearly there. We had our equipment, we had Liz on site, we'd had all the negotiations with CHO7 for our clinic teams, and then suddenly we were threatened, you know, that it might not get off the ground. So honestly, it really was because of the teamwork and the determination that we just said, you know what, we're just going to go around and over all of these obstacles, and we're just going to persevere. You know, got Liz established in the clinic. She was extremely flexible, you know, whatever days the clinics were available, that's the way she worked around just to get it off the ground. Great rapport with the patients from the very beginning, and of course amazing clinical support and backup from Professor Tierney. So all in all, you know, the confidence grew as the months went by, and it just went from strength to strength. And I suppose from a TALA kind of corporate point of view, you know, we're very conscious of the fact that, you know, over 600 patients, there's just simply no way these patients would have received that level of care if we hadn't had this Sláintecare initiative up and running. We're so grateful. Liz touched on the fact that they felt so safe coming to see her. And now, as Carmel said, you know, they can see Carmel in Kildare, which is just amazing for them. But ultimately, you know, we're just passionate about patient care here, and it's been well worth all the hard work, you know, and we really do hope that we can continue, and as Sean said earlier, hopefully expand. You know, this is a template that's been proven to work, so we're hoping that we can roll it out further.
That's great. Thank you very much for that really interesting and exciting news on the initiative that's having such great outcomes, and the patient experience is bearing testament to the success of your work. So can I thank the four of you for joining with us, and we'll have a chance maybe to talk with you a little bit more during the panel conversation later on. Thank you all very much.
My name is Sarah Phillips, and I was referred to the leg ulcer clinic by my doctor. The waiting time was minimal. Attending this clinic is so much easier than going to the hospital. With the COVID restrictions, I feel safer, as the clinic is one in and one out. I have no fear of sitting in a waiting room with people. I see the same nurse, which makes all the difference. We have developed a great relationship. It is so easy to ask questions, and I was assured that I could call if I had any issue or concerns about my leg ulcer. I am so grateful for the care and attention I have received. The healing is positive, and I thank you from the bottom of my heart. Thank you.
What a strong testimony there from Sarah Phillips, finishing that clip. Happy with the new service that's meeting her needs close to home, and so important that she feels confident that her healing is going so well. Congratulations to the whole team there. Okay, we've come to the part of the webinar where we bring back many of the panelists, many of the people that you've met earlier on, and they're now going to join us for a panel conversation. We have some questions coming in on the feed, so we will invite the panelists to come back. I'm joined by Melissa Currid and Adele Brennan from the Falls Prevention team. I'm also joined by Linda and Emer from the COPD, whom you met a little moment ago, Deirdre Carroll from the Oncology Service, and Professor Sean Tierney and Liz O'Neill from the leg ulcer project that we literally just spoke about there a moment ago. So you're all very welcome back. Thanks for sticking with us despite the blackout earlier on. Melissa, can I come to you and Adele first of all? Maybe Adele, there's a huge interest, Adele, in the Strength and Balance program. I've had a number of people asking, where can we find the detail? I think we could use that. So people are wondering, is it possible to get the details of your Strength and Balance program? And maybe in answering that, you might also tell us a little bit about how many people the project is reaching. Thanks, Adele.
Yes. Well, Gloria, the Otago and the FAME posture stability programs they're specialist falls prevention programs, and they're the ones that I use in my program. And I'm actually very fortunate to have done my training in both of these programs. So that's why I'm able to deliver these programs to my classes. Because the great thing is, you know, I give 6 classes a week and not one class is the same. And I'm able just to tailor the class due to this training. You're asking about the caseload as well, Gloria. There, at the moment, our active caseload for the team is over 300 clients, but this is spread across all the disciplines of the service with the clinical nurse specialist, the therapy assistants, and the physiotherapists. And that's one of the advantages of having the group classes. You know, we're able to see 6 clients per class, and now those numbers are reduced because of COVID. But as you know, we were given 6 classes per week, so it's brilliant. We're able to see a really, you know, a large cohort of clients in our area.
Great. And Adele, reading between the lines there then, is your response to Helen, you know, she would need to be trained in that particular program in order to be able to deliver it? That's what I hear you saying. Fair enough.
It is a specialist training.
Great. Okay. And it's working well. So the training obviously is well worthwhile. Thanks very much for that.
Thank
you. Linda, can I come to yourself and Emer and the COPD project, and would you talk a little bit about, you know, how did you engage patients? How did you actually get the service users engaged in the project that you were running?
Yes, Gráinne, patient engagement was really a core element of our project management approach, with the project very much focused on delivering patient-centered care, better patient outcomes, and improved patient experience of service delivery. So we invited a patient champion onto the project implementation team, and he was well known to the service, and he's also local lead or local COPD support lead. So he was an ideal link between patients and the healthcare team. So he was involved right from the start of the project. He participated in team meetings, and our process mapping workshops, he was able to provide insight into the patient experience and really ensure that the patient perspective and their needs and priorities were taken into consideration in the design and the development of the integrated care services. And he continues today to participate in the ongoing monitoring and evaluation of the services and service outcomes. In December also, we implemented a service user experience survey, and as the team highlighted, that provided assurance of significant patient satisfaction with the new services to date, and also that those new services were effectively meeting patient needs. In addition, the availability of outreach clinics in 2 geographically convenient locations in the county, one in Waterford City and one in Dungarvan, helped to address the needs for easier access to service and care closer to home for service users. And the patient feedback to date really highlights that these outreach locations are viewed as a great advantage for that patient cohort.
Great.
And from a clinical perspective also, the clinical team, they work collaboratively and in partnership with each patient, very much focused on addressing individual care needs and goals and supporting patients and families to develop skills and confidence in self-care management.
Great. And that model of engaging patients in mapping the pathway, mapping the journey is so important to see it from their perspective. And you can see the richness of that then in meeting those needs and perhaps seeing things that maybe as a clinical person you wouldn't necessarily see because you're not, you know, sitting in the shoes of that person. So that's really good, I think, public engagement. Deirdre, coming on to yourself in terms of the oncology service. When you were starting this project, what were the biggest challenges when you were looking at this and thinking, okay, we're going to do this? What were the biggest challenges that you faced?
I suppose, Grania, our biggest challenge was there was no precedent to this type of community oncology treatment, of delivering this type of care in Ireland. So we spent an awful lot of time scoping out and working through the policies and the processes that we needed to set up to deliver this service. I suppose secondly then, time was a big challenge, particularly of course in the last 12 months. It was a huge ask for our busy colleagues in the Mater Cancer Care Directorate and our senior management team to take time out of their busy schedule to work with us on this project, while at the same time delivering care as usual and doing additional work because of COVID on top of everything else. So that was really challenging. And I suppose then finally, access to hospital systems has been a big challenge for us. Our nurses here in the CIT clinic are employed by primary care, but we need access to the hospital systems so that we can order blood tests and we can review the results, and also so that we can record oncology medication administered in our clinic.
Very good. So there's something about connecting those systems to talk to each other so that the communication channels and indeed process channels are clearer. Thanks, Deirdre, for that. Can I come to Liz and Professor Tierney in the legal services? Maybe to you, first of all, Sean, some questions coming in about, you know, delays, that there's countrywide, there's a difference in the length of time people might be waiting to access a vascular consultant. And I suppose my question to you is, can you speak a bit about the key clinical challenges that you faced in managing this move of care into the community?
Well, of course, that's precisely one of the reasons we wanted to set up this service, is that there are quite long delays in access to outpatient clinics. But a lot of the patients who come to the clinics could be managed using an alternative pathway, such as the one we've set out. So as I've said already, we've saved 600 clinic appointments, which improves access for other patients and actually puts patients through a pathway that's more appropriate to their needs. And I think in that way, you can make more efficient use of the outpatient clinic time and help even out that uneven access to clinics that we see across all sorts of specialties.
Mm-hmm. And Liz, in terms of the patient perspective, returning to that for a moment, the key benefits?
Oh, there's many, Grania. I do think though probably the biggest benefit for patients is that timely assessment. So as I said, between referral and actually clinic appointment, the maximum wait is like 2 to 2.5 weeks. The leg ulcers, the majority of them are venous in nature, and the gold standard treatment is compression therapy. So it's generally the underuse of compression or the use of ineffective compression that delays healing for these patients. So what were small wounds have ended up into being chronic wounds before they've been got to an outpatient setting. So by coming to these clinics, we can do a comprehensive vascular assessment. We do toe pressures and we do Dopplers that can determine to us the status of their vascular health. So they're getting into the right treatment at the right time. So this early intervention will aid healing because we're basically getting to them from the get-go. We're not delaying any treatment. Being in compression itself has huge benefits for the patient. It reduces swelling, it reduces pain. Often ulcers can be quite odorous, and that's very distressing for patients. So being in the right dressings and the right compression therapy, it can maintain that odor. The biggest as well benefit is the time we have for these patients. So we have time at the appointments to give education about their vascular health, to discuss their risk factors and what they can do to prevent it from getting worse. We talk about diet and exercise and the basics of keeping your legs well. And we empower patients to better manage their disease, like what the COPD girls were saying, that basically patients, if you self-identify and self-manage, it does result in better outcomes. So the whole health promotion is huge in the clinic. And because we have those hour slots, we have time to give that to patients.
Very good. Excellent. So just to finish off then with each of you, if there's one thing, I mean, you've been running these various projects, you've had Sláintecare money. If there was one additional piece of support or a bit of wind in your sails that you've identified the project needs to get it up there, to get it right around the country, for each of you, I'm just wondering, what would that additional, let's go back to Melissa and Adele in the Falls Prevention Project. If there's one thing, one extra thing or one more thing that you require to really, push forward the work that you've been doing and make it the complete success you want it to be. Melissa, Adele, what would you ask for?
I suppose a continued specialist service. You really need, we have a specialist clinical nurse, we have a specialist physiotherapist, and that's what you need to deliver a specialist falls prevention service.
Very good, makes sense. For Linda and Emer, if there's one thing, what would you be asking for? If I could gift you something, what would you be saying? Oh, Grania, give us this. What would it be?
We're in the processes at the moment of setting up an improved clinic where we can provide patients with a service that would give them spirometry, and we would also be able to give ABG analysis, so looking at arterial blood gas analysis in our clinic. That would avoid the patient having to present to the hospital for these specialist care. So we're working on that. We're hoping that we'll have that in our project soon.
Okay, very good. Deirdre, for yourselves, the one thing that would give the project a whoosh, get it over that line that you're thinking, oh, if we just had that, what would it be, Deirdre?
I would say probably access to a shared patient electronic record would be great for better integration of care.
Yeah, and we've heard that from a few people over the last 8 webinars, and I think hopefully there's project being made on that. And finally then, to Sean and Elizabeth in the leg ulcer service, what's the one thing? I can gift you one thing. What would it be to make this the best project that you could possibly make it?
I think hugely important, Grania, is actually finding the right people with real enthusiasm to start something new and turn it into success. And like we have a fantastic team, and that really has made all the difference.
Yeah, lovely. What a great way to finish. Thank you all so much. So thanks to our panelists, thanks for all of the really interesting, wonderful interviews that we've done. I want to thank each of you here today. I want to thank Laura McGahey for her message at the start of the webinar. Well done to all the great Sláintecare project work as it continues. Today's emphasis on alternative care pathways for so many patients by moving care into the community successfully is certainly, I think, a message of hope, and it really concretises what Sláintecare seeks to deliver, and I think shows how these innovative ways of working are making our health and care services better for all. Thank you to the team here who helped produce this session: Rosaline Harlan, Muriel Farrell, Lindsay Dre, Ingrid Doyle, Erica Kinsella, Suzanne Lynch and Tom Dukes. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website, and do send us your feedback. The questions we don't get a chance to answer in the webinar will be posted in the coming days. So from me, Gráinne Healy, please stay safe, wash your hands and hold firm. We'll see you all next time. Thank you.